Hearty good morning to one and all. I'm Dr. Aahan from Jipmar, and today I'll be presenting a case on keratoconus. So, an 11-year-old school-going male child was brought to the OPD by his mother with complaints of frequent and vigorous rubbing of the eye for the past 2 years. Apart from this, the child also had irritation and watering from both the eyes, complaints of difficulty in seeing the blackboard, and there's history of chronic eye rubbing, also history of skin allergies and recurrent cold, which are aggravated in winter season. There's no history of any spectacle usage or contact lens usage for this patient, no history of discharge, photophobia, or pain, no history of long-term usage of topical medications, no history of previous consultation for eye-related problems. He doesn't have any relative in adolescent age group with history of frequently changing glasses. There is no history of any medical illness or abnormal joint mobility. The child is conscious, cooperative to time, place, and person. He's well built and adequately nourished for age. There is no evidence. Rest of the systemic examination was within normal limits. Ocular examination showing head posture erect, eyeball position orthotropic, uncorrected visual acuity being 612, not improving further. On retinoscopy using cyclopentolate drug with working distance of 0.66 meters, the best corrected visual acuity was at minus 3.25 diopters of sphere and minus 5 diopters of cylinder at 10 degrees, 6, and N6. Retinoscopy by direct distant ophthalmoscopy showing scissoring reflex and Charlot's soil droplet reflex. Eyelids, there is no sign of Munson sign is negative, eyelashes normal, some papillae were present. Coming to the examination of cornea, the cornea was clear, there was no evidence of any thinning or Fleischer's ring. Now in this figure you can see that there is inferior thinning. I'm sorry, the mouse is not working, but in the lower image you can see that there is inferior thinning and over which there is an area of steepening. Also on making and slit, you can see that there is a whitish line which disappears on pressing the globe. There is no evidence of any prominent corneal nerves, no evidence of protrusion of the cornea. Anterior chamber depth, Rizzuto's sign was positive, pupillary reaction was within normal limits, IOP was 14 millimeters of mercury. And this is the left eye examination showing similar findings, corneal thinning noted inferiorly below the apex with few parallel stress lines present in the deep stroma that disappear on pressing the globe, suggestive of Ward's try. So this is the diffuse slit lamp examination showing Rizzuto's sign and the Munson sign being negative for this patient. Fundus examination was within normal limits. So to summarize, an 11-year-old male presents with complaints of excessive eye rubbing and difficulty in vision since 6 months. On examination, signs like Ward's try, Rizzuto's sign, scissoring reflex, oil droplet reflex were seen, with rest of the examination being within normal limits. My provisional diagnosis for this patient based on the signs and the age is both eye keratoconus. I like to proceed with anterior segment optical coherence tomography, corneal topography. And this is an AIOCT showing that there is no evidence of any focal thinning and no evidence of any epithelial abnormality. The pentacam scan showing asymmetric bow tie with inferior steepening, but there is no skewing. There is flattening in the anterior and posterior floats with more in the posterior float, suggestive of initiation of keratoconus changes. Package showing more than 100 microns of difference between the central and peripheral corneal thickness. And Balin's Ambrosio enhanced ectasia is showing that the enhanced best fit sphere is showing pathological changes favoring the predisposition of keratoconus, and also the corneal thickness spatial profile is reaching 2 standard deviations, suggesting the same. This is the same for the left eye with asymmetric bow tie, inferior steepening, and no skewing for the radial axis, and posterior float is showing more flattened areas with significant thickness changes. Again, the same finding here. So the stage will be Amsar chromic stage 2, ABCD stage 2 with no evidence of scarring, and these are the KISA percentage for the right and left eye showing increased severity in the right eye. So since the patient was from far, we decided to go on with C3R based approach because the follow-up was in question. So based on dressing protocol, the patient was approached with C3R.
You can skip this, you are running short of time.
Yes,
skip
sir.
the procedure of CXL. Yes.
Yes. And then post-operatively, this demarcation line is seen, suggestive of increased corneal strengthening. Thank you.
So thank you, Aahan. Most of us knows about keratoconus, but for PGs, this could be a long case in your exam. So all the signs as Aahan highlighted that you should remember, and CXL Yes, just for the discussion purpose, what are the indication of CXL? Because you highlighted one important aspect. If you are sure that the patient is not going to come back for follow-up, it's better to go for CXL. So which are the indications of CXL in keratoconus?
Sir, as apart from this point, if there is documented progression in terms of topography, that the ectasia is increasing, the thinning is progressing, then we should go for C3R. And it should also be done with usually more than 400 microns of residual bed thickness. If it's less than that, then we should be cautious in the use of C3R.
So what's the take of the panelist on this point?
If the
When would you prefer to go for CXL without even documenting progression?
the patient is young age and who is in the age of progression, like below 15 years, they are more prone
Yeah,
for
yes, ma'am.
progression. So those patients, even when we don't see the progression, even on the topography, we go for CXL.
Yes, ma'am.
Tushar?
Pedia.
Somebody in teens, especially early teens, you would go ahead with cross-linking without looking for progression. But somebody in their 20s especially, even in early 20s, you should look for progression, do serial topographies, and then
Since
consider
this was an
cross-linking.
11-year-old male child with reduced age, severity can be high with the lack of compliance for follow-up. So,
And in kids, also look for VKC. Yeah, that's also an important factor.
Correct. So you mentioned that there were giant papillae here. So when you're talking about management, you should also talk about treating the VKC. Because
yes.
that is also
Yes.
important for you to prevent the progression of keratoconus.
yes, yes,
And
correct,
even
sir.
in the history, it would have been nice if you asked for a history of eye rubbing, because all of these are quite relevant to the condition that you diagnosed.
Understood, sir. Thanks.
So VKC treatment is important from two standpoints. One is itself, the eye rubbing causes progression. Secondly, if you go in with a bad surface, post cross thinking, you are likely to have sterile infiltrates, and you want a good response to the cross thinking, right?
Yes, ma'am.
For the epithelial off treatment and the epithelial on, I think largely the debate is moving in favor of
Iontophoresis based treatment.
remove the epithelium and use other modalities to circumvent the. Yeah.
So the point for all of you is, if you are suspecting the patient is going to progress, as Tushar highlighted, right? Patient below 19 years and having risk factor like VKC with eye rubbing, then in those cases, it's better not to wait for documenting progression and go ahead with CXL. For those cases, you can directly go with CXL even with one visit. And second, as ma'am highlighted, if the patient is having VKC, the ocular surface is altered. So sterile infiltrate, and there is a high risk of moxifloxacin resistant keratitis in post CXL patients. Okay, so there are two wonderful series, one from Narayan Netralaya, one from RP Center. You can go through that. So control VKC before going for CXL. Thank you, Aahan.
Thank you so much, sir.